Now, I know you talked about fluid therapy with Natalie in your previous class, but we're going to focus in on some topics in Chapter 15, just kind of help you out a little bit as you continue to prepare to get into class, to clinics. First of all, when we're talking about fluid therapy, we need to know how much fluid does this particular animal need. And there are 3 values that are calculated to determine the volume of fluid to administer. First of all, we need to take into account the hydration deficit. So they could be 0% dehydrated, so not dehydrated at all, perfectly hydrated, or they could be up to 12% dehydrated. Now, it is important that you understand that we can't really determine if they're less than 5% dehydrated. We're going to call that 0% because we can't determine that by looking at clinical appearance, making a judgment on that. But you should know the difference between an animal that's 5 to 8% dehydrated versus 8 to 10% dehydrated versus 10 to 12% dehydrated based on your skin turgor, the position of their eyes, if their eyes are sunken in their head, if they're able to move at all. So you should be able to determine that, and you should be able to list why that animal is that particular dehydration. Then we go to maintenance requirement, and that's just based on the animal's weight. How much do they need based on what they weigh? We also need to take into account their contemporary or ongoing losses. This means that we need to measure how much urine are they putting out, about how much are they vomiting, and how much is coming out through the feces or the diarrhea. With maintenance fluids, it's about 40 to 60 mils per kg per day. With cats and small dogs, it's an inverse curve. So with cats and small dogs, we're actually going to see them need more, 60 mils per kg per day. So an average 5 kilogram cat's going to need about 300 mils per day. With large dogs, they need about 40 mils per kg per day. So a medium-sized 20 kilogram dog or 44-pound dog would need about about a liter a day. So a 44-pound dog getting a liter a day, that's what they need to maintain their fluid rate. If we need to add to that because they're dehydrated, we need to take into consideration their percentage of dehydration. If they're losing more because they're vomiting or having diarrhea, we need to take that into consideration as well. So how do we determine the dehydration? Less than 5%, not detectable. 5 to 6% loss of just a slight loss of skin elasticity. You have to be very careful with a very old or very young pet because that's not going to really figure in. With 6 to 8%, you're going to notice a delay. It's going to be a noticeable delay in return of skin to normal position. There will be a slight increase in capillary refill time, and the mucous membranes will be dry. At 10 to 12%, the skin will remain tented. They will have continued increase in refill time. The eyes will be sunken in the orbits. They will be tachycardic and have weak pulses. At about 12 to 15%, they're going to be in shock and or heading towards death. Remember that the percent of dehydration is just the percent of the animal's weight in kilograms that's been lost in the form of fluid. And if we remember that 1 kilogram equals 1 liter, we can figure out pretty quickly how much water that animal has lost in terms of weight. So a 22-pound dog, that's 10 kilograms, that is 10% dehydrated, is missing 10 kilograms times 10%, or 1 kilogram, or 1 liter of fluid. This needs to be replaced on top of the maintenance fluid that they need, plus any more that they are going to continue to lose with vomiting and direct diarrhea. So if we go back to our 20 kilogram dog, okay, and we think that that's twice, excuse me, I don't know why that's doing that. That's twice the size of this dog, okay? If we are needing to replace maintenance fluids and dehydration fluids, so the dehydration fluids is 1 liter, the maintenance fluids would be 500 milliliters, so that's the dehydration fluids is more than the maintenance fluids, okay? So we're already replacing this. Today, we need to get that animal 1.5 bags of fluids, 1,500 mils of fluids, and then if they're losing more, if he's continuing to have vomit and diarrhea, we need to add to that. The rate of administration is going to depend on the condition of the animal and any underlying health issues. So if we're putting fluid in, we need to make sure that it's going to be able to move throughout their body. A shock dose, so the most we want to give them, would be 40 mils per pound per hour in dogs and 23 mils per pound per hour in cats. Anything that decreases the rate of perfusion in the animal will decrease the rate at which you can reperfuse the animal safely. So if there's heart failure or renal failure or some types of shock, we need to reduce the rate that we're giving to them because they won't be able to pump that fluid out of their organs and into their tissues at a normal rate. So we will just need to slow down a little bit. We also want to be very careful and monitor any patient on fluid therapy for signs that the fluid is being displaced outside of the vascular system and into the tissue at too big a rate. So if they're overhydrated, we're going to hear some crackling and rattling of the air through the fluid in the lung sounds. We're going to see fluid dripping from their nares, so there will be fluid dripping from their nose. They may be coughing. They may be having trouble breathing. They may be really restless because it's really uncomfortable to get so much fluid. So we want to watch that very, very closely. And again, you do need to remember these doses, 40 mils per pound per hour in dogs per hour in dogs and 20 mils per pound per hour in cats. We also need to remember that fluid is in a couple of different compartments. We have intracellular fluid, that's fluid in the cells, and this makes up 60% of your total body water or 40% of your total body weight. So a lot of your fluid is inside the cells. Of your extracellular fluid, fluid that's outside of your cells, that's 40% of your total body water, and 30% of that is in your interstitial tissue, so in between the cells, and 10% is in your intravascular. So 10% of your total body water is in your blood. That is 5% of your body weight. So 5% of your body weight is in your bloodstream. When we talk about fluids and how to replace fluids, we have to know what osmolarity means and what tonicity means, and they are different. Osmolarity is the measure of solute concentration per unit of volume of solute. It's not the same as tonicity. It takes into account all of the solute concentrations, not just the ones that can't cross the semipermeable membrane. Whereas tonicity is the measure of an osmotic pressure gradient between two solutions. Unlike osmolarity, tonicity is only influenced by solutes that cannot cross the semipermeable membrane, because these solutes may be influencing that osmotic pressure gradient. So we can have an isoosmolar solution that are not isotonic, because osmolarity is taking into account even those big solutes that have to stay on one side of the membrane, whereas tonicity takes into account those big, doesn't count those big things that are not crossing the membrane. It's only counting the stuff it's not counting the stuff that's crossing the membrane, it's counting the stuff only that's not crossing the membrane. We also need to know what a milliequivalent is, because a lot of the things that we see in fluids are measured in milliequivalents. The milliequivalent is the weight of each of these ions based on their atomic weight. And so it kind of evens these things out so we can understand how much is actually in solution. So 1,000th or 10 to the negative 3 of a chemical equivalent is equivalent weight. Concentrations of electrolytes are often expressed as milliequivalents per liter, which is an expression of the chemical combining power of the electrolyte in the fluid. So we're not only taking into account what's in here, the amount that's in here, but how does it combine? How does it dissolve in solution? Crystalloids are solutions that contain electrolyte and non-electrolyte substances capable of passing through cell membranes and therefore entering all body fluid compartments, so intracellular, extracellular, interstitial, and the bloodstream. It's categorized as replacement, and this resembles extracellular fluid or maintenance, which has less sodium and potassium in it. Crystalloids are used for dehydration, shock, maintenance fluids, balancing electrolytes and nutrients, and as a vehicle for administering drugs. Some examples of some crystalloids would be physiologic saline. This is 0.9% solution of sodium chloride. This means we have 308 milliosmoles per liter, and it's called normal saline. This will increase plasma volume and correct hyponatremia because it has sodium chloride in it, but it should not be used in animals with heart disease because we want to avoid extra sodium. Lactated Ringer's is a balanced electrolyte replacement, and it has 28 milliequivalents per liter of lactate. So that's bicarb, which is a buffer for acidosis. We do not want to administer it with blood products, so if we're giving a blood transfusion, we're going to use physiologic saline, not lactated Ringer's. And we don't want to use it in critical patients. If we have a critical patient, typically they have some electrolyte derangements and metabolic, like pH derangements, that we need to be a little bit more precise with as far as supplementing bicarb or removing bicarb. Dextrose 5% as water is a non-balanced solution containing 50 grams per liter of water, pure water, because dextrose will turn into CO2 and water. We do not give sub-Q because dextrose is a large molecule and it's going to draw fluid from the vascular space, so you never want to give it sub-Q because of that. And also, you don't want to give it sub-Q because dextrose is a sugar that will feed bacteria. So if you stick the needle in sub-Q and you happen to drag some bacteria in with it, you've created a nice big bacterial culture that will create an abscess. We do not use dextrose 5% in water for maintenance fluids because it will actually dilute out electrolytes. Ringer's solution is a balanced electrolyte solution that contains more sodium, calcium, and chloride than lactated Ringer's solution. It doesn't have lactate in it. So if we have an animal suffering from metabolic alkalosis, which if you remember is fairly rare, then Ringer's solution would be the choice. 2.5% dextrose in 0.45% this is half strength saline. So 0.9 is normal, 0.45 would be half strength. And then if we add potassium to it, this is a maintenance solution that's appropriate for patients with sodium restriction, so for heart disease. Another one would be Multisol or R or Normasol R. This is a balanced multiple electrolyte solution with some dual buffering, both acetate and gluconate. It is calcium free, so it's better for use with blood transfusions or for adding sodium bicarbonate. Normasol M is in 5% dextrose is a balanced maintenance with acetate as a buffer. Acetate tends to be a little bit more of a stable buffer than lactic acid. Plasma Light and Plasma Light M in 5% dextrose is a balanced replacement with both acetate and lactate as a buffer. We're going from crystalloid solutions now to colloid solutions. Colloid solutions contain solutions that have large molecular weight particles unable to cross cell membranes and are confined into the vascular space. If you're giving it in the vascular space, which you should, okay? So it's going to draw fluid from the interstitial space into the vascular space. The effective osmoles that draw fluid from the interstitial phase to expand the plasma volume are albumin, plasma, and synthetic colloids. This would include dextrans and hydroxyethyl starch or hexastarch or he-starch. They're used to treat hypovolemic shock, so if we have a shock due to the fact that we're losing fluid, septic shock, if it's due to a major infection, and they can also be useful with cerebral or pulmonary edema or when crystalloids are not helpful. The dextrans is a large molecular weight polysaccharide used for shock. It can cause clotting defects or allergic reactions in some patients, so we have to be careful. Oxyglobin or oxypolygelatin, it's also known as betaplasma, is a modified animal collagen, denser than the dextrans, so it has more osmotic action, but it can also cause some clotting defects. Hetastarch or He-span is a large molecular weight starch used for hypovolemia and hypoproteinemia. It does expand the plasma volume longer and have fewer side effects than the dextrans, but it is very expensive. It's used most often, these colloids are used most often in emergency medicine or in surgical, major surgical procedures. Hypertonic solutions are used for the treatment of shock associated with trauma, endotoxemia, burns, pancreatitis, and major surgical procedures. It's also useful for patients in which brain or pulmonary edema is a major complication. Hypertonic solutions, if it has it's not osmolar, but it's hypertonic. So it's got large molecules that cannot cross the blood-brain or the barrier, the vascular barrier. And so it, again, will pull fluid to it. Some side effects are phlebitis, so inflammation of the vascular system, tissue irritation, rehemorrhage with traumatic shock, electrolyte imbalances, and if the administration rate is too fast, then we can get hypotension, bronchoconstriction, and bradycardia. Some fluid additives. When we talk about spiking the fluid so that we can supplement things that are missing, we can supplement sodium bicarbonate. This is basically baking soda. It corrects metabolic acidosis and can be used as an adjunct if we have hypercalcemia or hyperkalemia. Lactate or acetate in fluids really can't correct severe acidosis, so we really need to supplement if we're using Ringer's solution or sodium chloride. We're going to add sodium bicarbonate to this. How do we know how much to supplement? Well, if we measure the carbon dioxide level or the bicarb level through a blood gas, then we can subtract that from 24 milliequivalents per liter, which is normal. We take our deficit times 0.3 times the weight, and that tells us how much to administer in milliequivalents. So we get it. That's our dose. The deficit, what our bicarb deficit is, times 0.3, which is constant, times their weight, kilograms. Okay, and then you can give that amount in milliliters to the bag. Potassium chloride is used for the treatment or prevention of potassium deficits. We do have to dilute it before we administer it. Typically, when we give them potassium chloride, we're going to put it directly into the bag of fluids, but we absolutely have to watch the rate at which we give the fluids, because if we give potassium chloride too quickly, it will stop the heart. Calcium, we can dilute this with saline 1:1, so half and half, give us a solution. It's usually given full strength for treating emergencies like milk fever or eclampsia. If they have hypocalcemia because of a parathyroid gland disorder, the eclampsia or milk fever, or excessive sweating in horses, that's when we use calcium. But we do have to watch the rate. Again, it can cause hypotension, cardiac arrhythmias, and even cardiac arrest. 50% dextrose can be used for caloric supplementation, but it can't meet the total caloric need, so we do have to be careful of that. It can be used in hypoglycemic patients. Hypoglycemia is caused by fever, sepsis, insulin overdose, insulinoma, and liver disease, among other things. In order to make a dilution of dextrose, you need to know how to do the calculation. And the calculation is the volume of the first fluid times the concentration of the first fluid is equal to the volume of the second fluid times the concentration of the second fluid. So if we are looking to make something with a concentration that is very high, like 50%, into a concentration that is lower, like 5%, okay, and we know how much we need of that 5% solution to give. So say it's 30 mils, okay? If we know that that is what we want, okay, then what we need to do is solve for the volume of this first solution that we're going to give. Okay, so if this is 50%, and we have 30 times 5 over 50. Okay, so what you need to do is you need to multiply 30 times 5 which will give you 150, and you're going to divide by 50, which will give you 3. So if we take 3 mils of this 50% solution, and add it to water, you have to know how much water to use, and that's 3 minus 30, which is 27 mils of water. Okay, that will give us 30 mils of a 5% solution. Okay, so you need to know how to make these dilutions in order to add the fluids. Okay. Some other supplements that we can add to our fluids. We can give vitamin B complex, which contains vitamin B1 and B12, which we know is good for the GI tract. Also can stimulate the appetite. Vitamin A, if they're low on vitamin A, vitamin D, vitamin E, and vitamin K. This is a great way to understand what kind of fluid you're going to need based on the abnormality, the diagnosis that you have. It tells you what type of dehydration you're looking at, what kind of electrolyte balance you may have, the acid-base status that is normal for this type of abnormality, and then what fluid therapy you're going to use. You might want to print this out because this could be super, super helpful for you in practice. So for instance, if you just have simple dehydration due to stress or exercise, then it's going to be a hypertonic dehydration. And you just need some half-strength or balanced electrolyte solutions or 5% dextrose solution. If you have acute renal failure, down here, acute renal failure, it could be isotonic or hypertonic if they're vomiting. In which case you're going to have potassium retention and you have to measure your sodium and chloride because that will be variable. Almost always you're going to have metabolic acidosis, so you need to do a balanced electrolyte solution. If you look through this, most of these say acidosis. Okay, they're all metabolic issues. They're almost all acidosis. So if you can remember that hyperadrenocorticism causes sometimes a mild metabolic alkalosis, and if you can remember that vomiting can cause, if it's acute, can cause a metabolic alkalosis, okay, then you know what you're dealing with. Everything else is acidosis. Okay. And then you can look through here and you can see that most of these are going to require a balanced electrolyte solution. Occasionally we see that we want a Ringer solution or full strength, normal strength saline with potassium chloride. It's going to tell you what kind of supplementation you need. If they're starving, half strength or balanced electrolyte solution with potassium chloride and calories are going to be important. So a lot of different, lots of information on this slide, and I highly recommend that you print this out and keep a copy of this with you because this is going to help you in clinics tremendously. That's it for our fluid therapy talk, and we can discuss this and go through how to do dilutions and some more fluid calculations in class.